Welcome to the post-lunch proceedings of Day 2 of the 7th World Congress. We're about to commence the proceedings with a keynote address on dilated cardiomyopathy to be delivered by Professor Asha Moorthy from Chennai. And to chair this keynote address, that will be delivered for 13 minutes, followed by 2 minutes of observations from the chairpersons only. And being a keynote address, we'll not be having any questions from the floor. May I invite Dr. Hanumant Reddy from the United States of America. Flanking him as the co-chair is Dr. Satish Mahajan. I'd request the chairpersons to kindly invite Professor Moorthy and set the proceedings in motion. And may I request all delegates who possess mobile phones to kindly switch it to vibratory mode. Thank you very much. Over to the chairpersons.
Good afternoon, everybody. This is a post-lunch session. A keynote address to be delivered by Dr. Asha Moorthy. She is Professor and Head Department of Cardiology, Shri Ramachandra University, Chennai. Since we are lagging behind the schedule, I straightway request Dr. Asha Moorthy to deliver her keynote address on dilated cardiomyopathy. Dr. Asha Moorthy, please.
Thank you, Chairperson. At the outset, I would like to take the honor and privilege to thank the untiring personalities, Dr. H.K. Chopra, Dr. Naveen C. Nanda, Dr. Parashar, Dr. Rakesh Gupta, and the other organizing committee for giving me this wonderful opportunity to present at this August gathering. Actually, I have been attending so many conferences, more than I think 200 to 300 conferences. But WCC is one of the very unique conferences in the sense that it is always with the scientific feast, with all stalwarts. There is always a spirituality and which relaxes the mind. And you could see that with the fag end of the day, you feel so fresh and you're not tired as usual with the other conferences. So with this introduction, I start my presentation. Dilated cardiomyopathy, the current strategies management of 2012. The historical perspective started in 1785 with William Withering, who discovered the first foxglove digitalis for the management of heart failure in Roman times. And you could see these tubes which were used for draining the fluid. The heart failure, the main line of treatment, apart from the digitalis and diuretics, AC inhibitors was one of the most important revolutionized drug. In 1628, William Harvey described the circulation, and in 87, the consensus trial with the enalapril. 1995, European Society of Cardiology gave guidelines for the heart failure, and in 2010, American Heart Association, American College of Cardiology gave the guidelines for the management of heart failure. Dilated cardiomyopathy is a heart muscle disorder which is defined by the presence of a dilated and poorly functioning left ventricle in the absence of any abnormal loading conditions. That is, there should be no cause of any hypertension, no valvular disease or ischemic heart disease. It is of no etiology cause, but there is the presence of dilated cardiomyopathy with the systolic global impairment. The large number of systemic and cardiac disease can give rise to this presentation with the dilatation of the ventricles, and patients comes with the phenomena of idiopathic dilated cardiomyopathy. The epidemiology of AC inhibitors, that is to start with the consensus trial in 87, SOLVE trial of 1992 with the enalapril, SAVE, TRACE, AR, hopes with the Ramipral in 2000, which blowed up the history that Ramipral can decrease the mortality and morbidity in patients with CAD, can also prevent mortality and morbidity in patients who are going for CABGs, and so many of the advantages of using Ramipral. Accomplished trial realized STITCH, the utility of the drugs, has come a very long way in the management of patients with heart failure with dilated cardiomyopathy. And one of the most important drug is AC inhibitors and beta blockers. It has been found that the drug enalapril definitely has decreased the mortality 12.4%, and with the MERIT HF and CBS2, we have found 7.8% reduction in the mortality over the last 1 year when the patient was put on beta blockers in combination with AC inhibitors. And also, it decreases the sudden cardiac death. The causes of dilated cardiomyopathy has been predicted that in young patients it could be because of myocarditis, it could be because of carnitine deficiency, selenium, anomalous coronary arteries, Kawasaki's, and endocardial fibrinolysis. There are so many important causes which has been impacted for the cause of dilated cardiomyopathy: non-compacted myocardium, calcium deficiency, and in adolescents and adults it is familial idiopathic dilated cardiomyopathy, X-linked, alcohol, myocarditis apart from that, tachy, cardiomyopathies, mitochondrial, and so, and nutrition also. A patient with dilated cardiomyopathy presents with shortness of breathlessness, swelling of feet. The symptoms are very atypical. Sometimes patient will go for a stage 4 NIH classification and you will not have any symptoms, but suddenly you will find the patient has got dilated ventricles with ejection fraction of 18%. So patient comes with the swelling of feet, a chronic lack of energy, difficulty in sleeping during night with orthopnea, swelling and congestive, the features of swollen heart, swollen abdomen, cough when the patient lies down, increased urination at night, and confusion and impaired memory. These are some of the presentation of dilated cardiomyopathy. Now, what are the investigations we come across? The first thing which we have to do a patient is we have to take a chest X-ray, we have to do electrocardiogram, we have to do echocardiogram, and the series of hemolytic tests, serobiochemistry, radiological studies, CT angiogram, and the recommended biochemistry test is ESR, creatine kinase, viral serology study, renal function, LFTs, thyroid functions. In X-ray, you can see the dilated X-ray test shows a cardiomegaly. It can be moderate, it can be severe. And X-ray and the ECG shows a various pseudo-infarct pattern. It can have STT changes, it can have a non-specific STT changes. Patient can present with the RBB pattern, with the conduction deformities, can have a sinus tachycardia, or very vague type of presentations can be seen in the ECG, which will not be very clear-cut to say that it is a case of dilated cardiomyopathy. And you could see the bundle band defects. You can see the various atrial fibrillations, atrial flutters. Now, echocardiogram has revolutionized the treatment, management, and early diagnosis of patients with dilated cardiomyopathy. You could see that there is a global dilated ventricle. You can see the MR associated. You can see that there will be a mitral regurgitation, there will be tricuspidation as a consequence of dilatation of the ventricles. So it is related to the ventricular dilatation. As such, the valve is not affected. It is only the dilated ventricles which is giving rise to leaking across the valve. CT angiogram, which is done to rule out the patient has got a associated CAD. So you would find that the normal coronaries and MRI CT, a cardiac MRI also gives a very fruitful image about the end systolic and diastolic volume, the viability of the myocardium, whether this patient can be suitable for any revascularization if there is associated. But in dilated cardiomyopathy, absolutely the coronary arteries are normal. So cardiac MRI has of late has revolutionized the diagnosis of dilated cardiomyopathy because it gives the exact volume, exact viability of the myocardium, exact cause. The etiopathogenesis of dilated cardiomyopathy, who patient comes with a poor left ventricular function with a myocardial damage. The patient comes with a decrease in stroke volume, decrease in the cardiac output. And with this, there is a response, a neurohormonal response in which there is an activation of sympathetic system and renin, angiotensin, aldosterone system. Two systems are activated. So with the result of this activation, there occurs a vasoconstriction, increase in the sympathetic tone, angiotensin 2, endothelians, impaired nitric oxide release. So what will happen? With this consequence, there is a retention of sodium and salt, and patient comes with the ventricular wall dilatation, fibrosis, remodeling, and with the worsening of further heart failure, the patient comes with a sudden cardiac death and the further sequences of the problem. Microvascular spasm is also one of the contributory factors for the dilated cardiomyopathy. It has been found that with the matrix dissolution, there occurs a cardiac dilatation, diffuse focal myocarditis, fibrosis of the myocardium, cell loss, fibrosis, there is a myocardial hypertrophy, and then subsequently what happens, there occurs a biochemical dysfunction, fibrosis, and patient comes with the myocardial failure. The renin substrate angiotensin system is activated, as I told you in the previous slide. So with renin, there is a conversion to the angiotensin 1, and with the angiotensin converting enzyme, it is converted to 2, and there is an endosteroid release, there is a vasoconstriction, enhanced sympathetic activity with the salt and water retention. The diagnostic criteria for idiopathic dilated cardiomyopathy is based on the ejection fraction by echocardiogram, less than 0.45%, fractional shortening is decreased by less than 25%, and the diastolic dimension should be more than 112% predicted value for the age and body surface area. And exclusion criteria is absence of systemic hypertension and coronary artery disease. You have to rule out all these possibilities, pericardial disease, systemic disease, before labeling this patient as a case of dilated cardiomyopathy. And the key is the criteria for left ventricular enlargement, as I told you, according to which with the diastolic dimension should be more than 112% of the predicted age and listening. The treatment algorithms for newly diagnosed patient with the diagnosis of dilated cardiomyopathy comes with the recent American Heart Association and American College of Cardiology. They have labeled as ABCD. Those patients who come with the A group, they are high risk for developing heart failure, but there is a presence of underlying heart disease. B is the asymptomatic heart failure, in which there is a history of previous MI, there is a left systolic dysfunction, or patient can have an asystemic valvular disease. In C, patients come with a symptomatic heart failure with a known structural heart disease. And end stage is D, in which patient comes with a refractory end stage, which the patient requires a transplantation, the heart failure. The AHA guidelines for the heart failure management is based on the stage 1, stage B, and stage C and stage D. The first line of management, diuretics, decongestives with digitalis, and AC inhibitors, ARBs. And finally, the patient who comes with the refractory heart failure, they have to be given left ventricular assist device, they have to be given immunomodulation, they have to be given immunosuppression therapies, and they have to be given a cardiac transplant with the final group. The specific treatment is not available for most of the patients with idiopathic dilated cardiomyopathy. Therefore, the primary aim of the treatment is managed on symptoms to prevent sudden death, to prevent thromboembolism, and diuretics remains the central to the management of congestive symptoms, but they should be used, not be used as a monotherapy, but they should be used in combination with beta blockers, AC inhibitors, and with the beta blockers and spironolactone also in added group. Of course, the management of arrhythmias in idiopathic dilated cardiomyopathy is very important because there are substantial limitations to mostly currently available antiarrhythmic drugs in ADC, in particular because of the negative inotropic effect and pro-arrhythmic effect. One of the two large studies which has evaluated amiodarone in IDC, but only one Jessica trial have demonstrated the improvement in overall prognosis. But there are as yet no large-scale randomized data of implantable cardioverter defibrillator in treatment with IDC. But it is reasonable, it is very documented, it gives a sustained hemodynamic response for those patients who come with the unstable ventricular tachycardia and ventricular fibrillation. Please remember that, ladies and gentlemen, the implantable IDC cardioverter defibrillator is one of the mainstay in the patients who come with the refractory heart failure and who come with the arrhythmias. So this is the biventricular pacing CRT, in which one catheter is put in through the coronaries into the LV, one is in the RV, and you can see kept in the RA. So this is the biventricular pacing, is a very useful cardiac resynchronization therapy for those patients who are coming with refractory heart failure, who do not respond to the medical therapy, who have come with the failed therapy, can give an option of choice for CRT. And a combo trial of CRT, biventricular pacing, with cardioverter defibrillator can be given as a choice, as a combo treatment. Cardiac please continue this, just 1 minute. Yeah, just stand some. Can you go to the slide? Just last slide. So cardiac reconstruction therapy, as I told you, improves the left ventricular function, and along with ICD, it definitely has a role in reversing the remodeling. And implantable cardiovascular has a role in patients with the, this is one of the patients with the left ventricular access divide in Ramachandra hospital, which was given. These are some of the left ventricular access devices. So the future of IDC is, challenges are there to treat, and immunomodulation and immunosuppression is one of the mainstay in the treatment. The novel potential pharmacology treatments are natriuretic peptides, cytokines, antagonists, and anticoagulants with the new therapies. And of course, the partial left ventriculotomy, left ventricular access device, and multi-site ventricular pacing is one of the mainstay. And finally is the cardiac transplantation. So with this, ladies and gentlemen, I thank you very much, chairpersons, for this kind listening. The final go of treatment is cardiac transplantation is available, the best treatment for dilated cardiomyopathy. Of course, I didn't mention of pericardium cardiomyopathy because pericardium cardiomyopathy also presents with dilated cardiomyopathy, but they respond very well once the trigger of pregnancy goes off. They do well, and the ejection fraction also improves. But with the repeated pregnancy, I think they will go back to the same form of decreased ejection fraction. So the trigger of pregnancy has to be taken out, so the patient should be avoided pregnancy in the future. Thank you, ladies and gentlemen.
Thank you very much, Professor Moorthy, for excellent and elegant lecture. Just only 1 minute. I just want quick comments. It's very, very hard to summarize such a vast topic in 10 minutes. But a couple of things. You mentioned many tests in a cost-conscious environment. Now we're going through the whole globe. So if you are do cardiac catheterization versus CT angio, I think cardiac catheterization is probably the most important thing, because you want to rule out congenital heart diseases, valvular heart diseases, and also rule out coronary artery disease. I think that's the most cost-effective. So CT angio would be basically will be incomplete, and also radiation is higher. Now, number two is what do you think about stem cell implantation? Of course, that's the future. And the other thing is you talked about immunomodulation. Would you like to give it in the beginning when you suspect myocarditis, or towards the end? So there are two questions I have for you.
Yeah, this treatment of stem cell therapy can be prescribed the end. Once you have ruled out when patient is not responding to medical therapy and to your other conventional therapy, I think we can give as a choice of stem cell therapy. Definitely, there are some reports, statistical analysis in which they found that there is some improvement in the left ventricular ejection fraction, those that come with a failing left ventricle, before going for left access devices.
Great. And one last question. When would you like to consider the patient for immunomodulation? In the beginning, when you do heart biopsy, when you suspect myocarditis, or towards the end?
No, once when you do a biopsy, and you come to know that there is a mechanism that this immunomodulation can be helpful. It can be prescribed at the beginning itself.
Yeah, thank you. Thank you very much for an excellent talk.
Yeah.
And this concludes our session. Thank you very much.
We got a medallion. Ladies and gentlemen, may I now request our chairpersons to kindly present a medallion and a citation to Professor Moorthy. Thank you very much, gentlemen, for chairing the proceedings of this session, and to Professor Moorthy for delivering this keynote address.